welcome to the Health and Wellbeing Board. We're the first meeting of this municipal year, so before we start these proceedings, may I bring to your attention some housekeeping matters. We're not expecting a fire drill today. Therefore, if the alarm sounds, please follow the fire and emergency procedure that are applicable to the council house, which basically says you leave by the nearest door and we all meet up down in front of the council building. Obviously, not immediately in front of it, but by the fancy new paving. This meeting will be broadcast live to the internet and will be capable of subsequent repeated viewing. By entering the Warspite room and during the course of the meeting, committee members are consenting to being filmed and to the use of those recordings for webcasting. Please can I ask that you speak clearly and directly into your microphone when addressing the meeting so that the online participants and the public can hear, and that it's switched off when you're not using it. Your mobile devices are turned to silent, she says, quickly checking. So thank you for that. Apologies.
Thank you, Chair. Quite a few today. Apologies from Councillor Lang. Councillor Down is substituting. Apologies from Gary Wallbridge. Mark Collins is substituting. Apologies from Chris Morley. Nicola Jones is substituting. Apologies from Mark Hackett. Amanda Nash is substituting. Apologies from David Haley. Temi is substituting. Apologies from Matt Garrett. Apologies from Michelle Thomas. Jeff Baines joins us online. Apologies from Robert Fern, and apologies from Rob Smith. Thank you.
Can I say thank you to those of you that are subbing for other people? I know I had a moan at the last meeting because we had quite a few empty chairs, so it's really good, and I will always welcome a substitute if needs be. I'd rather have somebody from that department area there that at least, if they can't answer, you can take it back and get the answer. So thank you very much to those of you that are giving us the time today. So moving on to item 2, do members have any declarations of interest in respect of what's on the agenda? No, right, we're all happy. Chair's urgent business? None. But I'd like to welcome Kathy, who was here last year as substitute off and on, weren't you, I think, during the year? Yeah, but welcome, and it's good to have you on board. Patrick is also on this committee, but obviously he's not here at the moment, but we will welcome him. And I think that's basically all, isn't it? Because the rest of you that are substituting, we're straight with that. Excellent. So the minutes of the last meeting. Tony, you and I were here. And I think that's probably, Ruth, you were around, weren't you? So, Tony, are you happy?
Yes, I am.
Thank you. Excellent. I'll sign those in a bit and they will then go into the records. So, our first guest. Can I say a big thank you to you for Candap, and Rachel obviously was going to come along, but I don't know if you've got anything you'll be adding in, Nicola, or since Rachel's not here, or whether we leave it to the two gentlemen to sort this out and to bring us up to date. But thank you very much for coming along, and we appreciate that setting up a new pharmacy within Derriford, the Derriford site, has been not without its difficulties, shall we say, including the electronic difficulties. I believe the computer was saying no at one stage and you were having good fun, and that was before last week's global thing that happened. So I look forward very much to hearing what you've got to say. Have you got a presentation that's up on the great stuff? Amanda, do you just want to close the door too, just so that if anybody's wandering by chatting too hard, loud, that it's not going to disturb us? Thank you.
Brilliant. So I just thought we'd kick off, Mary, by introducing ourselves. So good afternoon, everyone. I'm Vivek Soni and I'm the Deputy Chief Pharmacist at the Trust.
And good afternoon, everyone. I'm Kandar Thacker. I'm the Chief Pharmacist for the Trust. And like with most Chief Pharmacists, you use your powers of delegation. So Vivek's luckily doing most of the presentation, but hopefully I'll get involved with the Q&A.
So just really like to begin by thanking Mary and the board for inviting us along today to give an update on the outpatient pharmacy service at the Trust, which, as I'm sure you're all aware, has recently changed provider from Lloyds to Boots Pharmacy. I think as per the brief during the presentation, we'll ensure that we cover those topics that you were keen to find more out about, so accessibility to the pharmacy, patient waiting times, and how we face the challenge of some of those IT issues and sort of medicine supply issues at the time of go live. So I thought it was really important to begin by just touching on some of the background and history of the pharmacy service, but I'm sure as local residents and users of the Trust, you may be familiar with some of this information. So the previous provider, Lloyds Pharmacy, was in situ at the Trust for over 10 years. And I think it's fair to say that the outpatient pharmacy service had perhaps failed to meet the changing needs of the organisation and our patients, particularly due to the growth and demand in clinical services. The previous premises, which the pharmacy operated on, was perhaps inadequate and too small in size to dispense the volume of prescriptions it needed to. Because we didn't have the space, it couldn't keep the stock holding of medicines, there were often long queues, it was overcrowded, and there was no real sort of facilities for patients to wait comfortably. There's also perhaps a lack of flexibility in the way that patients could collect or receive their medicines. I suppose in this more sort of virtual world, with most patients actually having to come on site and queue and then collect their medicines. And I think the poor patient experiences was probably reflected in the increasing level of complaints that you would have seen in the local media or were raised to the Trust via our local MPs. So when the contract with Lloyds came to an end, or it came to that point where it's up for renewal, the Trust took the decision that they wanted to go back out to market and go out to procurement for a really high quality pharmacy outpatient dispensing and retail service. I have the next slide, please. So in February 24, following a robust procurement process, the Trust decided to award the outpatient pharmacy service to Boots UK, with the service going live at the beginning of April this year. One initial benefit of the new service, that it was going to operate from a brand new unit located in the multi-storey car park at the Trust, and this unit was going to be double in size at 155 square metres, so immediately we could solve that space issue. In addition, the new contract was going to offer numerous additional benefits for patients and staff alike. So the first benefit, and something we're particularly proud of, is the fact that patients would be able to collect non-urgent prescriptions from a local Boots store, and Boots have a really good footprint of stores across Devon and Cornwall and service our full footprint all the way from Barnstaple to, say, Penzance. In addition, we'd still provide a courier service for those vulnerable patients or those that simply weren't close to a Boots or couldn't come on site to collect an urgent prescription. Another big game changer for us was that we're going to move to an electronic encrypted prescription and essentially get rid of the paper. I think at the moment lots of our prescribing happens following remote virtual consultation, or it might be prescribing after an investigation. I think this just gives us clinicians more flexibility and essentially stopped patients and staff having to physically walk prescriptions up to the pharmacy. A couple of other benefits of the new contract was that there'd be an enhanced retail offering for staff and patients, and the pharmacy would now be open extended hours across the week with a Saturday service. So in terms of pharmacy access and location, I think if I'm really honest, there's perhaps no perfect location for an outpatient pharmacy, and it was just really to reassure the board that it was a strategic decision on the Trust's behalf to locate the new unit within the multi-storey car park. I'm sure, as you're all aware, there's huge pressure across the trust estate, and this location was perhaps the only viable option from our scoping exercise. And for us, it ticked a number of different boxes. So the unit we're being offered obviously met our size requirements. It was located within the multi-storey car park, which is now the main patient area. You could walk up to the pharmacy from the main outpatients, and then from a sort of more strategic direction of travel, it's going to be opposite our future developments, so the new build, the UTC, and the planned care centre within the northwest quadrant. I think as the clinical lead for the project, it was really important to me that I engaged with all the correct stakeholders, and I had really good support from our patient council, so from Jim Griffiths as the chair, and then from Sue Williams, who joined my project's steering group. I also came to present to Padan as well, and it was really important to me, with the pharmacy being at the top of the hill, that we put in the right mitigations for our vulnerable and disabled patients, particularly taking into account wheelchair users. So just to quickly highlight some of the measures that we put in place to sort of mitigate, is that there's now priority parking spaces outside the front of the Boots pharmacy for pick up and drop off, and that's something we couldn't offer with the previous offering outside Lloyd's, where it's just general sort of pick up and drop off for the trust. There's disabled parking, so the blue badge spaces within the multi-storey car park, so wherever you park on the trust site, if you need to drive up and utilise one of those, you've got the option. We still have our mobility shuttle, which can be called from the main entrance and take patients up to Boots. There's now more seating and a better waiting area within the store. We've got some prescription tracking software, so there's screens within the Boots and a screen within our main entrance, so patients and staff can see when prescriptions are ready, and they now also receive a text message when Boots receive their prescription and when it's ready to collect, so they're only really touching point with the pharmacy when they need to. But perhaps the biggest game changer with the electronic prescription, that if it's something that's non-urgent, that patient doesn't need to visit the pharmacy at all, and they could just pick it up locally as they would do a prescription from their GP, or we could courier it out to the patient if we need to. So really just wanted to make you aware of the issues that we faced at Go Live, and I think for me it's really important to put these into context and perhaps say that you would expect some of these issues to have happened if you were setting up a new pharmacy or changing provider. And we'd reached out recently to pharmacy colleagues in Bristol and London, because they've gone on a similar journey, either swapping from Boots to Lloyd's or bringing Boots into their estate. And it's fair to say, actually, we all experienced very, very similar challenges. So there's definitely learning we can take as a sort of a pharmacy community. And if you're going to do this again, or we're going to advise a peer trust, we could perhaps share some better learning and sort of mitigations in the future. But I think really just to highlight some of those key issues we faced, it was quite a complex handover from sort of Lloyd's to Boots, and although as part of the arrangement lots of the staff 2P'd over, we did lose some of the memory as our pharmacist colleagues chose to stay with Lloyd's. And we had the issue in the last sort of week before Go Live, there was lots of unfulfilled prescriptions, so then there was an immediate need for Boots colleagues to make sure patients had all essential supplies. In the first week of Go Live, we experienced some critical IT failures and network issues at the Trust, which was particularly challenging as we're trying to implement this new electronic prescription. And at times, we had to revert back to our business continuity option and to utilise paper prescriptions. One of the real biggest challenges for us is that actually the Boots pharmacy didn't have all of the medicines in stock that it needed to, because Boots unfortunately had restrictions on its account placed by some of the national medicine suppliers, and to this day we're still not 100% sure why that happened, because Boots have got, I think it's 14 hospital pharmacies within the UK. They're obviously a reputable company, some might say a cash-rich organisation, but for whatever reason, they had restrictions with the suppliers setting up these new accounts, so we really had to work really hard with them to unblock these. And as a mitigation, we either ordered in on their behalf or supplied various medicines through the Trust hospital pharmacy. In addition, we've struggled to get the text messaging service to work for the first sort of months to 6 weeks, so we can offer that functionality. Patients and staff alike seem to struggle a little bit with our new operating model, in the sense that if it's an acute prescription, the clinician ticks that it's urgent on the electronic prescription, Boots start working on it straight away, and then the patient comes to collect. But we had shelves full of urgent medicines that nobody had collected. And I think likewise with the non-urgent items, which are then supposed to be dispensed and then ready to collect in a local store in 48 hours, we often had patients that would leave their consultation and say, turn up in Boots, Drayton Circus, expecting to pick up an item immediately. So there was lots we had to do with comms just to really explain that piece. I think because of all the operational issues, colleagues were unable to contact Boots via the various phone lines, the email inbox was jammed, and yet again it just led to a really poor experience for patients and staff. And I think this was evidenced by an increasing number of complaints and incidents we were seeing. So what did we do to recover the situation? So really like to stress that it's a real sort of joint effort between Boots and Trust staff to recover the situation as quickly as possible. And we had really good support and oversight from our executive team at the Trust. I think for us, although we contracted the service out to Boots because we feel they're in a better place to run it than ourselves, we really do see the fact that we work in partnership with them, and the outpatient service is really just an extension of the Trust. So we jointly did everything that was within our gift to resolve things as quickly as possible. So we worked with Boots to resolve all the supplier issues, and then they've now got all the medicines they need at the right stock levels in store. And Boots took some of the feedback on board and actually reconfigured the store after those first few weeks of opening to remove some of the retail items to create more waiting space. They improved the signage so it was clear what patients needed to do when they were handing in and collecting prescriptions. They went above and beyond the staffing model and appointed additional staff, some of those into admin roles to help with some of the challenges we were seeing. They leaned upon the memory within their organisation and brought in colleagues from across their network of hospital stores to help and support. I think the additional staffing and the help from colleagues meant they could really focus on a timely response to emails and complaints. We iterated the comms as we went to try and keep patients and staff as informed as possible. We've added new local stores for collection, so Kingsbridge and Torpoint, because we realised that there was sort of an equity issue in terms of access, and we've improved the functionality of our electronic prescription as we've gone, taking feedback from our prescribing colleagues. So really just wanted to sort of finish up the last couple of slides and talk about where we are today. And I think it's been, quite a journey for the past sort of three and a half months, but we really now feel that the service is in a really good place and settling down, and it's very much now sort of business as usual on a daily basis. So just to look at some of the headline figures, so we dispensed 12,000 items in May 2024, which is slightly more than we were doing with Lloyds. On average each month, over 300 prescriptions are being sent to local Boots stores, which is a complete game changer for our patients because the majority of those would have been picked up on site previously. We're couriering an average of 40 prescriptions a month to vulnerable patients directly to their homes. Whereas when the Boots first opened, waiting times were at least an hour. They're now comfortably down to 20 or 30 minutes, which is quite reasonable and what you'd expect to see in a community pharmacy. Within the month of June, I'm really pleased to say that we've had no patient complaints, whereas prior to that, I think we had probably 20 to 30 that we're working through. Likewise, incidents are down to 4 for the month of July, whereas I think in total we've had 80 or so incidents since the pharmacy opened, but really pleased to say that none of those have actually resulted in any patient harm. And just to really make sure that we're all providing the pharmacy service that we want to, we plan to do an extensive patient experience survey at the end of the first quarter, and that will be a joint endeavour between Trust Pharmacy colleagues, our patient experience team and Boots. So really just wanted to take the final slide to reflect on patient feedback, and I think for me that's perhaps the most important feedback from the users of the Trust. And you'll have all seen the negative press in the local media or on social media sites. I just wanted to touch by looking at a Google review, and I know it's only one review and a snapshot from the last week, but I think that 5-star review almost translates to what we're seeing on the ground. There are things that we need to optimize, but I think this really shows where we are today, and it's setting that expectation and direction of travel for the service moving forward. So perhaps I'll leave it there, and Candace, Amanda and myself are happy to take any questions that you might have.
Thank you very much indeed for that. And it's very heartening to know that the improvements have happened. I certainly went there quite early on, and it was a little bit baffling. And fortunately, I could go back, so it wasn't a problem. But I think it's reassuring. And I was at Padown the other week. I did not have any concerns issued to me then, so that to me is always a really reassuring sort of thing. And Amanda will know that well. That you know, they soon will let us know. So that's really great to hear. I suppose one of my questions to you is the list of drugs that you carry as stock or whatever. Do you do a trawl to see what your consultants or the clinics are prescribing? I know I had a concern raised by one gentleman that he had a particular drug, and I would not say it's a usual drug by any means, but it was prescribed by Derriford. Um, but he could not get it. And now we know with the national shortages, we know all of that's happening. But I'm just wondering, I just like some reassurance that you do that trawl of your consultants to find out what they're prescribing, especially people with long-term conditions. And I'll speak to you afterwards about a particular one if that's all right, Vivek. But you know, I'm not going to raise that, but just some reassurance on that.
Yeah, so definitely I can confidently say, Mary, that we work to a trust formulary, and we try to align to a Devon formulary, so we keep all of the commonly required medicines. And when we introduce any new medicines into the trust, we work really closely with our clinical teams to try and work out what their activity will be in terms of patient numbers. And as you say, we continue to iterate with that clinical services to always make sure we've got a reasonable stock holding within the pharmacy, or we know how to order the medicines very quickly. I think there'll always be one or two specialist medicines that you might order for the first time, or as you've alluded to, there's lots of national shortages, or there's quite a lot of fragility within the supply chain, and then we just work really hard to get the medicines as quickly as possible. But what we make sure we do is we make sure the patient and the clinical teams are aware of the situation, and if it's then prudent to prescribe an alternative or to take a different course of action, we do that, or to reach out to other trusts and colleagues for mutual aid, etc. Yeah.
Thank you for that. And then the other thing about Fridays, dear old Fridays. So clinics will be carrying on Friday afternoons. If it's a long clinic, etc., it may well carry on till I think boot shuts at 6, doesn't it? So if you're that poor soul that's been the last appointment and you've not got in till 5:45, so by the time you've seen that you had your appointment, how are we managing that bit? Because obviously they could go to their local Boots, etc., and that isn't a problem. But is there something that it perhaps bypasses your system so it goes straight out into the community?
I'll take that one. Thank you. No, it's a great question. I think it's probably important to start by saying that when we looked at the opening hours, what was really, really clear is that we needed to open on a Saturday, which is what we've done. Boots were always up for discussing longer working hours on certain weekdays or all weekdays. But as you'll appreciate, in terms of prudent use of taxpayers' money, we had to sort of start where we are and then review that. So it's important to say that that's a possibility, that we could look at certain days and see if we need to increase hours. The second bit worth saying is that when Boots is closed, we do have the offer of patients bring their outpatient prescription to the inpatient pharmacy. So we try to do that as an exception rather than a norm, but we absolutely do that. And our pharmacists out of hours have access to the electronic prescription, so they can get that. As I said, we try not to encourage that because there's enough to do the inpatient pharmacy, but we absolutely can do that when required. And I guess lastly, then, and you've touched on that already, Mary, in that we're seeing at the moment that up to 50% of our patients are collecting medicines close to home. So it is only the minority of patients who will be in that situation, but they've got the inpatient pharmacy as an option. And perhaps at 6 months, we will look at the opening hours as well.
Thank you very much. Right, I'm going to open it up now. Anybody else got any questions? Tony.
Thank you, Mary. I think it's more of a statement than a question. I think 12 months ago when I came up to UHP to talk about all the patient experience and the negativity around Lloyd's at that time. We had a good walk around and we had a conversation, and I think it's really generally good to see the improvements that have come in. There are still one or two issues there, and I think there will always be issues that need to be worked on from an operational point of view. But I can say since the beginning of April, we have had no feedback about the 8 patients pharmacy at Derriford. So I think that kind of correlates a little bit with the feedback that you're receiving. And long may that continue.
Thank you, Tony. Patrick?
Yeah, thank you, Mary. Thank you very much indeed. Very informative presentation, and well done for all the excellent work that's gone on. I want to just pick up, if I may, where you say Boots give support to colleagues on other sites, because certainly from a local perspective, some other Boots in the city, particularly in Plymouth, where there have been other closures, have had a detrimental impact on the customer experience. So we've had queuing. So I'd like to know a bit more about how they support those other sites. And clearly by, which is a really good idea, pushing out the prescription to the local store and people not having to travel to Derriford is an excellent move forward. But what's been the detrimental impact potentially on branches? And I think, you know, Boots seem to have a particular problem with staffing compared with other pharmacies. So what are they doing in terms of, what are you doing to monitor the performance in those other local branches? And do you, when you monitor performance, and you've got here a monthly KPI performance, do you look at waiting times or process times for prescriptions, both at Boots at Derriford in this new facility, but Boots in that are around the city, please? Thanks, Mary.
I'll start. I'm sure we'll want to come in. I think it's probably worth saying, and it sounds like a bit of a disclaimer, but it's important to say that we recognise the issues at community pharmacy across the board. And actually, at risk of going slightly off tangent, when sometimes we are challenged around why can't somebody just get a green prescription and go off to their local community pharmacy? One of the reasons we don't always encourage that, I mean, there's lots of reasons, is we recognise that that's just transferring workload to a sector that's already really at capacity. So we absolutely recognise that. I think it's also perhaps fair to say that we absolutely monitor Boots and hold them to account against their hospital contract. And as part of what I'd call our wider social responsibility, ask questions about local stores. But I wouldn't be able to give you exact sort of KPIs around local stores. But what we do recognise is that the local stores have a system by which they can monitor what's coming through a hospital and escalate if that's causing a problem to their business as usual, so to speak. And so far, we haven't heard of that whatsoever. I don't know whether you wanted to add anything on that.
And I suppose from my perspective, the other way our model works is that we dispense all of the items at the Derriford site and then they're couriered to a local store. So the local store is just used as a pickup point. So we hopefully don't create a burden for the local store beyond just booking that prescription, which would trigger the text message. And I think one of the big things for us is through the procurement process, we wanted to utilise a provider's network of community pharmacies. And you'll actually notice that lots of chains are pulling back from the high street. So Lloyd's don't have a high street presence, others have rationalised their estate, whereas we're still assured with the coverage across Devon, Cornwall and Somerset. And we asked exactly the same questions as yourself, where you've perhaps shrunk your estate in Plymouth. How could you justify that? So they talked about how there'd be 3 branches, say in the city centre, they've gone down to 1 so they can really consolidate the staffing. In Plimpton, you had two branches from memory that were really close to each other, consolidate to 1 and offer a better service. So, you know, likewise, I think we're asking similar questions to make sure there was that sort of system approach to pharmacy services.
Thank you. Can I just come in with a supplementary? And it's in relation to, obviously, so thank you for your response. I think the added issues or added questions we ought to be asking Boots is how they triage. So effectively, you enter the branch and you stand in a queue. There isn't a triage of pass in your prescription. You have to wait until all the people. So they need to look at really their triaging of how they deal with the customer when they enter the premises. Because clearly, if they had sort of a queue that you pass your prescription in, you might only want to leave it. Other people want to collect things, and their queries, so they need to somehow look at, I think, improving efficiency. Now, that's probably not for you to answer today, but I think taking on board that it's fine, and I think it's really good that they can pick up, but some of those people are stood behind a long queue of people that are taking their prescription or having queries. And so I suppose the service they're getting won't be as good as it could be if they were to perhaps change their approach, the way they deal with people in their own branches. So thanks for all you do.
And of course, you are employed by UHP, you are not Boots employees, and I think that's what, so that Patrick, I think that query there you've made is a valid one, don't get me wrong, and I think we probably need to look at our other way of dealing with pharmacy things, of taking those to directly to the pharmacy.
So what I raise
people.
is that
Yeah.
UHP have a contract with Boots, so they have a way into Boots. And clearly, if part of the service is that somebody could go to, say, the Plimpton Boots branch, well, I think from a contractual point of view, you should be quite interested in what the relationship is for the service that the customer's going to get, because they're your customers. So that's the reason I raise it. I'm not saying that that Representative Day can answer
Nicola,
it.
do you want to come in on this from the ICB's point of view?
Thank you, Chair. I'm certainly happy to. So I work in NHS Devon, and we commission community pharmacies. Some of my colleagues work on that. I'm really happy if you would like for me to take that comment and suggestion and then feed to my commissioning colleagues and also perhaps to the local pharmaceutical committee who deal with these. I am mindful that every community pharmacy there will carry out some patient experience surveys from time to time, and I would imagine, perhaps that's being raised through there. But let me take it there in that way, directly into community pharmacy, and we'll see what comes back.
Thank you very much indeed, through you, Chair.
Okay. Thank you. Any other questions? Sue, yes.
Somebody else might have theirs on. My question is probably a bit of a strategic question. In so much as we know that Boots have closed quite a few pharmacies. So I can only talk about the city. And so when we commission with Boots and you've got this operating model, are they then under contract to be able to make sure that they do have those community pharmacies in the community? Because just as for instance, I just happen to know that they closed 2 of the pharmacies in my ward. So there's a whole ward of people now who have to go into the city centre. They closed a couple of pharmacies on the other side of the city centre. So all that particular ward of people now have to come into the city centre. So this model will only work if Boots are, as part of that commissioning process, to have a network of pharmacies, are actually going to keep them open.
So the really simple answer is yes. So the contract with Boots makes very clear that they need an access to a local network of Boots pharmacies. Now, can we hold them to account for individual stores? Probably not, as long as there's a reasonable network. And our mitigation to that, as Vivek sort of just touched on, is the ability where you're really miles away from a Boots store, and particularly if you're a vulnerable patient, then we would courier, and our numbers show that we do courier when necessary. So I guess in summary, yes, our contract absolutely makes clear about having a local network of Boots stores. But if they've got 2 stores and they choose to close one, that's harder to hold them accountable to.
And then just as a follow-up question, again, this is going back to Boots, and I know you might not be able to answer this, but I was very interested here where it said that the Boots at the hospital site took out some of their retail shelves or whatever products to have more space. Now that contradicts completely Boots' strategy, because part of the reason they said they were closing the smaller stores across the city was because there wasn't enough retail purchases going on to warrant them keeping the pharmacy open as a pure pharmacy. So again, that is just a strategic question, because it does throw up quite a number of concerns about how 2 sides of a coin are used depending what they want to achieve. So it really is a question for us to follow up in the future.
Yes, totally agree on that. That's very useful. Any other questions for the moment? No. thank you both for coming along. Now, I'm going to be cheeky and say, before you disappear, can Ruth have a quick conversation with you about the thing you were saying about the Boots network? It would be quite useful if all right, so catch you outside for that. So thank you very much indeed. That's, you know, we wish you well with this, because getting it right for a hospital pharmacy is very difficult. And I think all of us that have gone up to the hospital, those that have been going to the hospitals for various years and whatever, can remember sitting outside the old inpatient pharmacy and waiting for medication. So to me, at least having a Costa next door, shouldn't advertise, should I? That you can at least, the coffee shop next door, so that at least you go sit in there if you want to. It is just so much better. And I think, yes, there have been teething problems, but I'm reassured that if concerns are brought to you, that you're going to look at active ways to manage it, and that's got to be good. I mean, that to me is what the wellbeing part of this is all about. So thank you very much indeed for that. And I'll send an email to you about the specific drug that, because as I say, I'd never heard of it in all the years that I'd been within the but still. So thank you. Anybody else wish to come in at all before I say thank you to our guests? Thank you very much indeed. Take care. Bye. Right, folks. Nicola, the floor is now yours to give us an update. You're a very welcome addition, and obviously I'm hoping Chris is having a nice holiday or wherever he's gone, so welcome, Nicola. You always are welcome.
Thank you kindly. So here on behalf of Chris Morley, who's our interim locality director for Plymouth in NHS Devon. So I don't have a presentation, but there are a few written updates within your pack. So starting on page 9 of your pack, if I just touch on those in order that they are written, and then I'll do a verbal update, a little bit of information on dentistry as well at the end. So firstly, in terms of NHS Devon Integrated Care Board, we have a couple of key leadership changes, so that we will shortly welcome Peter Collins as our new Chief Medical Officer for NHS Devon. And Peter comes to us with experience as a CMO and other roles, as a doctor working in other parts of the Southwest, and he's due to join us in early October, and with some interim arrangements in between now and then this follows Dr. Nigel Aitchison's retirement from the NHS, from the organisation, as of a few weeks ago. And so we look forward to Peter joining. I very much hope that you will see and feel his influence from the Plymouth perspective, really important part of Devon, and also a nod there to Nigel's contribution over all of the years. He was certainly known as a very, a brilliant leader, a very compassionate person. So he brought something really, really valuable and important to his leadership. Secondly then, Kevin Orford is our interim chair in NHS Devon currently, with a process that will take place to identify a replacement chair on a permanent basis. So, and this follows Sarah Wollaston's decision, again a few weeks ago, to stand down from that position. Chair, I believe that Kevin has met with you, or will shortly has met with you, and hopefully again you talked about some things really important to the Plymouth population in terms of health and care, and as I understand it, maybe some more visits in the future. So I think that's really good news. That's a good step in the early days of his interim chair role. In terms of services then, 111, this is a service that most people in the population will be familiar with. Many people will use this either by telephone or digitally. And this is a service that I think is probably fairly high up in our healthcare conscious as a population, because it's a really important service and one that people want, sometimes in an urgent situation, sometimes for more routine advice and support, but it's something that we heavily rely on as a population and a system. And probably in this board, certainly in other committees, there will have been scrutiny about the role that 111 plays. The briefing here contains hopefully some assurance in terms of the ongoing work between commissioner and provider, in our case, Practice Plus Group, who they run services in Devon and other parts of the country as well. And there are some positives there in terms of some of the key performance indicators. So there's some stuff in terms of the amount of activity, the speed of their response, how people are finding that, and there has been some improvement recently. So it is always, work continues, absolutely. It's a really busy service. It's one that there's always a focus on getting as right as possible with, lots of challenges, demand, workforce, etc. But there are some positives in there, so hopefully useful. COVID sadly remains with us, doesn't it? And there is another COVID vaccination campaign. This is important. It is promoted heavily. Certainly, I see on social media a lot of people promoting this, whether that's general practice, UHP, Live Well, both for the population who are eligible. So that's these days people who are 75 or over, or living in a care home, or who are immunocompromised for various reasons. And so this is again being promoted. I think the arrangements are pretty good in terms of accessibility for people. People have become used to this, but nonetheless, there is always a focus on trying to improve the vaccination rates. Particularly, this is about vulnerable people, but particularly for people in the more vulnerable of those vulnerable categories. We see some of our, as sadly often the case, some people in the more socially deprived areas, we don't see such good rates. And so there is focus there in terms of getting the messaging, persuading people it's important, supporting with any assurance, and also the physical access for people to be able to have that done. So that continues. A specific service there in terms of a new service launched for women supporting perinatal pelvic health. This is a service for, has real physical impact on people who suffer through pregnancy and beyond, and includes, which I think is a positive, a self-referral facility that should be welcomed by individuals and also other services, so that you could just go straight to get help. Again, there's information online, and other professionals will be able to signpost. So that's a positive development. Another positive development in terms of prevention, so particularly in our with our older population, in this we target people who are 65 or older, but also we're looking a bit younger than that in terms of bearing in mind the frailty that some of our populations experience at a sadly younger age than that. And we are really pleased to have been able to continue funding from the ICB's perspective, and the provision now through Live Well and University Hospitals Plymouth in partnership, delivering it's known as our FAME service, the Falls Management Exercise Programme. This has a voluntary service component to it as well. So the Elder Tree voluntary organisation, who you'll know well, they play a part in this as well as in terms of follow-up programmes. And essentially it's a physical exercise programme. It's evidence-based, it's got really good evidence nationally, it's recommended in NICE, and was something that from a population health, a prevention of falls and all of the awful things that come with that in terms of for health reasons, for social reasons, for people's confidence, we know that there is evidence that those can be minimised. So that service is continuing. We've put that in place for another 2 years. So that's really good. The communication will be really important on that to promote it and try and really target the right people through that. Also on communication, and I won't do this anywhere near as much justice as my colleague Amanda there would, but we've given a nod there to UHP's ongoing really great communications programme, and there's a specific link in there that is recommended for you to have a look at if you haven't already. As I say, I think much of what we do in the health and care service, that communication and engagement is so important of. So we're, pretty much every programme of work that we undertake will and must have a communications component to it, in order that we get the services that we commission and provide delivered to the people who really need them. Finally then, in terms of the written briefing, support for people who have been discharged from hospital, so particularly perhaps for people who've been admitted to hospital on an unplanned basis, an emergency basis, and they may have been in hospital for a period of time. Returning home is a really important part of their progress in terms of keeping them safe and confident in their home. Many people will have friends and family or carers to be able to prepare the home ready for them to come home. But this is a really, really practical service in terms of for people who don't have friends, family who are able to do that for them. There is a service that is being re-procured to step in, and obviously with people's appropriate permission, etc., to be able to go into their homes and support. So whether that's cleaning out the fridge, getting milk in, getting bread in. Again, it's for for confidence, safety, and for is a really, I think, important service for people and the system. It helps people to be able to be safe at home. So there's a re-procurement. Just finally, if I may, on dentistry, I know NHS dentistry is a really high priority for this board, as it is for the Plymouth population. The need for improvements in accessibility to, i.e. the amount of NHS dentistry that we've got available to the Plymouth population, it's still there, isn't it? This is really high priority. It's a big challenge nationally and locally. I thought many of you work in terms of within the dental task force, I know, so you'll know more about that. There was a recent meeting of the dental task force, which is Plymouth City Council, NHS Devon, the Peninsula Dental School, University Hospitals Plymouth and Livewell, working in partnership with the priorities continue. So that's about increasing access, about and through there we've got things like the increasing amount of money that is paid to NHS dental providers on average, in line with national recommendations. So that those arrangements have been put in place. That should support keep maintaining the amount of dentistry that we've got available and also increasing it in those areas that need it. There's contractual work in terms of keeping our urgent care and stabilisation services going. There's another step up, as I understand it, in terms of activity this August. So some people will see some improvement there. There's a particular focus on access for people in vulnerable groups, including looked after children, some services making sure that they're cancer friendly, and also for our homeless and asylum seeker and refugee populations. That's not a whole list, but that's an indicative list of people in those vulnerable populations who this work is particularly important for, and I know the task force are working on that. More expression events. So there's, has been another period of putting out to the dental market in terms of existing providers, in terms of potential new providers, a process to get anyone, any appropriate provider who are interested and able to provide, to come to the table, as it were, and secure that. So it's an ongoing process. Finally, just to give a nod to the waiting list, sadly, but in reality, we have a waiting list of people. There's going to be some validation of that waiting list in order to really understand how many people have expressed an interest and said that they need dentistry, but also then to be able to once more dental capacity becomes available, to be able to offer that to the right people as quickly as possible. There's much more to it than that, but hopefully that gives a nod by way of an update in terms of those ongoing priorities. Is that all right?
Thank you, Nicola. I mean, one of those surprising things that I learned this last dental task force is there are very few other places that actually have an NHS dental waiting list. So it'll be really good to have somebody go through the list, contact people. Miggins may well have moved out of the country, out of the county, sort of thing. So we need to validate that. I mean, to actually be able to prove our list, there's not much point having 22,800 on the list if we then find out a huge number of them no longer are needing it, etc. So I think that to me is one of those important things. And also, we will be looking very carefully at anything comes out from government as to what they are now going to do, because certainly there has been a lot of discussion about what's going to be happening with the NHS, etc. And so we need to be watching that. But I'm very, so let's say I'm a little bit more positive now that certainly we have got those foundations there and there is respect for that task force. And despite what was said, it is not a talking shop. It has actually had some very good actions, and you know, therefore it's important we keep it going. And I'm not going to let it go at the moment. We are in no way near anywhere sort of leaving that at the moment. I'm going to come back to you, Amanda, in a minute, because I'd like to know a little bit more about your monthly news bulletin, because that sounds really quite exciting. But Ruth, and then Patrick.
Thank you. I just really quickly wanted to say that although obviously having a waiting list for those people who need dental care is useful, in reality there are probably thousands of people who just haven't got as far as being on the waiting list in the first place, or have looked at it and think, well, there's no point me even bothering to do that. So we've just got to be a little careful that we don't make assumptions that the waiting list is equal to the need in the city. And I think we do recognise that, but just to make that point.
Nicola? Yeah.
Thank you. Just a comment on that. One thing I have written in my notes about the oral health promotion programmes, just to speak to that point, Ruth, is for example, the dental school offered some dental support into schools in terms of whether, you know, advising children, and there wasn't nearly enough take up as was needed in terms of the known need in that population, just to reflect that point again with children. And there was, you know, so I know there's been work in terms of what to do with that capacity, really trying to, but persuading people, whether that's parents or guardians, that this is a really important service, even when it's sort of brought to you. There are people who don't take it up until maybe a crisis involves. Yeah, again, a point on communication. Thank you.
That's my homework for the summer, is to figure out how we get the schools that have had that offer to engage more. We need to know what the barriers are with that, so that is definitely my homework, along with various other people from the task force. So yeah, it's one of those top priorities. I've got Patrick, Sue, and then Kathy.
Thank you, Mary, and thank you, Nicola, for the update. Very useful indeed. Three little areas, if I can just touch on. If I just continue on dentistry, can we assume then that if somebody has an NHS dentist, that the checkup system should have been reintroduced post-COVID, because effectively they stopped in COVID? So can there be an assumption by a patient that a checkup would now be something that should be programmed in by a dental practice? So that's the first point. You might have his answers, Nicola, but you can always come back in due course.
I have to say, I'm sorry, I'm not absolutely sure about that. Might be that somebody knows, or I'm very happy to take that back and then get back to you. I'm sorry, I don't know that.
No, well, I can't expect you to know everything. I wouldn't know everything if it was fired at me. So I'm not. This isn't put you on the spot. This is just general interest. So thanks for that. The second one is access to GPs. Do we know if that's generally improving in terms, I suppose, against the level of complaints about the ability to contact a GP? And I think particularly older people who struggle with, and this is a growing issue, that people may be computer savvy, but their age deteriorates their ability to use a computer. So not that they can't use a computer, it's just that their eyesight might go, or, you know, the agility of their hands and so forth.
Systems are not always easy.
Then absolutely, Councillor Dan, they're not always easy. So do we know if that's improving? And the final question was generally on the finances for NHS Devon. I think historically there's been a sort of a legacy debt or a burden in terms of the finances. How are we in this financial year in relation to general finances? Are you carrying sort of excessive debt compared to from a revenue perspective? So it'd just be useful just to know where we are with that, because I'm sure the government will be asking for, and I know we at the local level have asked new governments and governments generally for an ask. So I'd just like to know what we're looking at the moment financially for Devon. Thank you, Chair.
Thank you. So on access to GPs, again, this is a something that people are working on every week. Access to GPs, so there are national and local surveys I haven't got the figures in my head, but for Devon, there is, you know, when we look at a range of statistics in terms of, you know, registration statistics, in terms of patient experience statistics, in terms of what people are saying about their general practice from the range of ways that they can have it. There are many of those facts and figures that are given more positive than the national position. We know that that doesn't always exist, and there are some real positives in Plymouth, and there are some real issues as well. And it is by no means sorted, but there is a push. In terms of the way to access your GP practice is absolutely part of that. And there are many people who will say, you know, once we got in, it was great. Once I had that consultation, it was great. But there was some anxiety that I had in terms of was I going to be able to actually get an appointment? And that's still there. You probably hear that in Health Watch, Tony, and we know that that's a problem. There are many people who are really pleased as well, but that is happening. There is some work. There's a way of working called Modern General Practice, which is a national focus, a national requirement of primary care networks to work with their component GP practices in terms of making their ways that people access their services and their triage systems for fit for purpose. And I think some of our, you know, there's some PCNs who've got a bit more to do on that, but there is work. I'll mention Mayflower. So Mayflower, with their new provider, have engaged, I think, really well with their population. That's through digital means often, but other ways of doing it as well. And they are looking at actively changing the way that people can access their services. And that's about giving more choice. And choice is often the thing that's important, isn't it? So that there is the online consultation mechanism. There's also being able to phone. There's also being able to walk in. And some people see that as going back in time a bit, but actually it's really important. That's what people want. If people, you know, if you have those modes of access in place, typically people are going to be able to find their way through that. So it's still work in progress. So I haven't got the figures in my head, but yes, I think everyone who wants to be able to be registered in Plymouth still has that, you know, that access is there. Yeah, it's a big topic, isn't it?
Yeah.
It's a really big
Probably
one.
sometime in the year, Chair, I would expect we'll have a report just that gives us a bit more detail. So thanks for the update. And then just on the finances.
On the finances, and again, I'm not too far with your finances are still.
Can we come back?
Can I come back
won't put you on the
with
spot.
figures because
Perhaps
I
if
want
you
to get
just
them
provide.
right.
It's just it's
yeah.
more strategic headline, sort of where are we?
Absolutely.
Because I know certain parts of the country struggle more than others. I think we were, you know, not good compared to other parts.
Yeah.
But probably because the size of the county as a general, and then the rural and urban. So yeah, just some feedback would be really helpful.
Yeah.
So thank you very much.
I will get that. I think it's true to say that the financial position is still very challenged.
Yeah.
There are, I think everyone working would say that some difficult decisions having to be taken, but there are improvements. But yes, I will come back with some figures. Thank you.
Thanks very much indeed. Sue.
You know, sometimes you get given numbers and you think, oh, that looks interesting, but what does it mean?
Mm-hmm.
So, you know, these 111 assessment validation numbers, I don't understand them.
Okay.
So I can't understand why the national targets are 50% and 75%. We're at 84.5 and 85%, and our targets are for ED are 75%. So I can't tell if we're validating enough, not validating enough, whether too many people are coming through for validation, or what does that mean? What does it mean?
Would you let me come back with a more detailed position on that? Maybe giving a range and the kind of the benchmarking, and those lines in terms of what's good and what's not, and what's happened over time. If I'll follow that up shortly, if that's okay.
So the reason I'm asking that is that the last time I was here, and it was a long time ago, a lot of the reasons we had high numbers going to the emergency department was because that through the 111 system they couldn't necessarily access GP services.
Mm-hmm.
So I just want to know, I can't tell from that performance whether because we've improved access to GP services somewhat that our performance has improved or not. So that was going to be my secondary question.
Yes,
That'd be lovely, thank you.
Yes, I will follow up on that if I may, if that's all right. the interface, as it were, between 111, out of hours services and general practice is again a hot topic. There are, I think patients are feeling that a bit, practices are feeling that 111. Let me come back then with a more detailed briefing that picks up on some of those points. Yeah.
Thank you. And I think the other thing that we notice with that as well is, unfortunately, the e-consult will often tell you to go to ED.
Yeah.
When with certain conditions, when anybody else knows that they don't need to go to ED for that, but there is some of this pushing to ED when it's inappropriate to push to ED, and I think that is something else that we need to get to the bottom of. But it's the electronic way of doing it, isn't it? That
Yes.
the computer says you've got a sore throat, so you must go to ED, sort of thing. So I think there's that, isn't it? And that's all that fine tuning that we need to getting through.
Yeah.
Ruth, did you want to come in there on that?
Yeah, if I can just help very briefly, that is basically saying that somebody checks what the system has done. They've checked whether, if the system is sending you to ED, was that correct? If the system called an ambulance, was that correct or not? So that's reviewed by a clinician, and it's saying that locally, not only have we set higher targets because we want to be better than the national, but also we've actually exceeded those for the ambulance, and the ED validation is. The ED validation has exceeded the target that was set, and the ambulance one is about the same. So essentially, we're doing better than nationally you would expect from that when the system is checked. So it slightly debunks the idea that is 111 sending, well, what we can say is that 111 isn't sending too many patients to ED or for an ambulance in this area. Relative to what it's doing across England. So we're not worse. In fact, it looks like we're better.
So that's a good service.
Yeah.
Yes.
But because we know the pressures then, so I would like to, so my second question is still valid. So within that, how many of those are because they can't, in the first instance, get the GP referral? Because I remember last time I was here, that was a real issue, which is why we have a GP now in ED. So it'd just be interesting to see how that's worked. Thank you.
Cathy.
Thank you, Chair. My question is regarding the falls management exercise programme. I just wanted to know how it was accessed, whether it was through a GP, physiotherapist, or whether it was advertised for, general consumption. How many people were actually able to use it, and whether it was exercise classes or whether it was individuals, etc. Thank you.
Thank you. So the precise arrangements are being finalised at the moment with LiveWell and with UHP, and but referral in is via GPs or physios, or the other people can refer in. There's also a self referral, and then there's a check in terms of eligibility and need. In terms of, so we try to, that self-referral is important because it empowers people just to be able to self-refer at that moment, and I think that's to take it, but also it means that if another, general practice time, for example, if general practice isn't going to add any value to that referral, as it were, then let's not take general practice's time. So that's that part. In terms of where the classes are, they're in a range of community facilities, really. And again, there's a focus on trying to get there's an availability of somewhere so suitable. I haven't got the list, but I can certainly send it to you, and it's on the LiveWell website. In terms of suitable venues, and again, trying to get places where we're going to get the best access for people. So having them in a range of places that people would feel comfortable going to, can get to. Bearing in mind accessibility will be challenging for many of these people. They may be relying on public transport or friends and family to take them. There was a programme of the FAME being delivered in people's homes. My understanding is that has been stopped. That wasn't going to be prioritised for continuation, and I think sometimes doesn't get as good impact for people. There's a value as well as the actual physical part. Some people get great value from the social interaction with people in these classes as well. But yes, and the communication again will be put out there so that hopefully everyone who needs this service will be cited on it. Yeah.
Jeff, and perhaps we can get you to help put some flesh on that bone to sort of make sure that we sense, because what I am going to be challenging Elliot is that there's a whole lot of good information that's come out from your paper today there, Nicola, and I think we probably need to think about how do we proceed that so that it's somewhere on the council's site, so that if people need to get it, we can. So that will be the challenge. So I'm going to quickly now go back to Amanda and just sort of say, can you just give us, a flavour of what's in your publication, shall we say, and is it monthly, etc., please?
I can, Mary. Can I come back on a couple of other points before I do that? Is that okay? First of all, to formally acknowledge the role of Nigel Aitchison and the strength and quality of his medical leadership since COVID and during COVID. In a time of great change and lots of leadership change, Nigel has been an absolute rock and a massive support to us at UHP. So we are sorry to see Nigel go, but very thankful for his tenure. Would be the first thing. In terms of the FAME programme, and I'm looking at Jeff as I say this, etc., and the support to discharge, these are all really important pieces of work because my colleague Mark is not here today because we have a relentless focus on our one plan to improve urgent and emergency care. And that one plan consists of 3 elements, and they are admission avoidance, dynamic flow within the hospital, and effective discharge. And things like the community care and the support in the community is absolutely paramount to the quality of care that we can offer in the hospital. And we're working really closely with our friends at Livewell, who are part of our one plan. We meet every Wednesday morning. And if we're going to get it right for hospitals, for ambulances waiting outside the hospital to come in, we need to get it right in the community. So those programmes are very much supported by us. The other point was Patrick's about digital inclusion. I just wanted to come back on the point of digital inclusion. I do chair, we have a Plymouth Healthcare Digital Inclusion Group, which includes representatives from Plymouth City Council and Livewell and other colleagues, looking particularly at digital inclusion from a healthcare point of view. In 2026, we hope to have our electronic patient record, which comes with a patient app, which has many, many benefits. But these things are only benefits if they don't exacerbate existing inequalities of access. So we work with colleagues around the patch looking at how we can come together and best leverage effort around digital inclusion. Some of that's about skills and capability. Some of it's around things like data poverty. So people not having enough data on their mobiles, etc. So we're working with places like the Good Things Foundation, and there are many hubs around the city that are data poverty hubs where you can go and you can be given data in a charitable way. So there's quite a lot of work going on around that from a healthcare point of view. Finally, our newsletter. Our newsletter comes out after board, and it just picks 3 highlights from what has been discussed and agreed at board. So at the moment, one of those 3 is often around our plans to improve urgent and emergency care, but there's often 1 or 2 other things as well. And the idea is to bring the decisions and things that are happening at the hospital to the public, and we also share on LinkedIn, etc. So we're really glad that that's building some support and some interest. It's trying to make us more transparent and accountable, and of interest because people want to know things like parking, for example, we have shared. So that's the purpose of that, and we will do that every month when we have a board meeting.
Thank you, brilliant. The more information that gets out there, people can access the easiest, and I think you're right. I mean, digital inclusion or exclusion is going to be one of those things. I mean, Sue and I often have a conversation about digital exclusion and how the councils deals with these things. So yes, we've got to be mindful. No 2 ways about it. So that's brilliant. Okay, folks. Now I'm just very conscious that we're about half an hour behind. And so I do apologise to our next guests. So Julie and Ruth. I mean, Ruth, you were here anyway, but Julie, thank you for waiting patiently there. So get yourself comfortable, and then the floor will be yours. And this is going to be about the Health Protection Assurance Report for 2022 to 23. Now, you might think that's a fair while ago, but unfortunately it takes a fair while to get all these bits and pieces together, so hence it's that far behind. So the floor is yours, Julie.
Thank you, Chair, and thank you for the opportunity to bring the report. So, as you may be aware, the responsibility for assuring that the health protection system is meeting population need is operationalised, if you like, through the Director of Public Health and through the Health and Wellbeing Board receiving an assurance report from the Health Protection Committee for Devon, Cornwall, Isles of Scilly that meets to kind of bring all that together. So essentially your report is a summary of that activity across the range of health protection areas, which are quite broad, as you can see, everything from responding to cases of meningitis to screening and immunisation programmes to preparing ourselves for pandemics, managing pandemics, and also other incidents, as well as monitoring infection prevention, control activity, antimicrobial resistance. And so you can see it's quite a broad-ranging report. So I'm not planning to go through all of it. What I thought I'd do is maybe draw out some highlights of some positive things and then come to any questions. So I think some of the highlights that strike me as I go back and read it, and it does feel kind of strange to read about COVID in the sense of 22 and the things we were doing because we were just emerging, and now we're making that business as usual, and we've lived with that for quite some time now. So it's sort of, it feels a little strange, but I think some of the key things that I've noticed from this is obviously the importance of the COVID vaccination programme, which features in this report, and I know Nicola has talked about in her update previously, and actually the amazing and broad-ranging amount of outreach work that has been supplemented, if you like, that delivery at mass scale of the vaccination programme, and how some of that learning has really benefited us. So it then speaks through some of the flexibility of that outreach vaccination programme team to help us respond to other emergencies, which you can see right through the response to the monkeypox and the support for the asylum seeker and refugee population in the hotels around Devon. So I think there's a really important learning, but good practice in the sense that's come from that. So that was one area that I thought maybe the board would want to recognise. I think COVID has also taught us about inequalities, and I think this report starts to show in some of that activity some of the other inequalities activities that are coming through. So in the screening programmes, the use of the health equity audit tool by providers, and work at targeting lower area uptakes at practice level, and using the data that we very much learned to use around COVID vaccination in that more real-time way. Other areas of note are the fact that the joint forward plan for the ICS has health protection as a particular section, which isn't uniform across other ICSs. So I think it's a really important to note that actually that has been prioritised and is articulated as such in the Devon ICS strategy. You can see the range of work and programme boards and things that are examining what's happening across that health protection agenda, and also the exercising, preparation, winter planning, checking care pathways, all the assurance activities that happen alongside those. We are lucky also, I think, to have the Community Infection Management Service that support our health and care settings with infection prevention, control and advice and support. We found that very valuable through COVID, but continue to do so. And actually, if you look at the kind of incidences that are being managed around, then care homes are a major kind of source of that. So we've definitely got good alignment there. In terms of ongoing, well, obviously there's a lot of these issues are not going away for us, and we continue to need to plan and develop our responses. Communicable disease activity in 22-23 was still significant, with other organisms appearing, such as the Group A strep and the monkeypox, and needing to bring responses to those. We're always seeking to strengthen our vaccination programmes. Our childhood vaccination programmes the under fives have stood up well through COVID, but if we're going to achieve those 95% pluses, then we really need to keep pressing on with that. And we have the maximising immunisation uptake groups are now formed to do that. I'm probably going to stop there and then to say, obviously, you can see the priorities that have been identified. There's progress reports against those, and that we have taken the view that actually those priorities are probably going to continue. So we're not going to be changing those annually. I think we're likely to continue, in a sense, building and iterating our work underneath them. We do refer to climate change, recognising that actually there are many activities already in place, so that it's just, in a sense, a way of taking and ensuring that the linkages of the impact of climate change and health protection are tied together, but not to duplicate other reports or other groups that are bringing information on that. So that's a summary. I'll be quiet now.
Julie, thank you very much. And certainly from my perspective, once we have the updates for this year for COVID and the flu season, how they're going to the winter preparations for that, obviously we will be wanting to make sure that all councillors know what that is, so that at least they can give that guidance. Taminola and Mark, I apologise, I didn't really give you the opportunity to say hello to everybody, so I do, I apologise for that. Taminola, I mean, one of those things that we come across every year are children, and particularly our looked after children, and making sure that they have all the immunisations, etc., and the care that they need and should be having. So I'm putting you on the spot here, and I appreciate you may not have the answers, so if you don't fret about it. We're just, if you can come back to us later. Sort of what I just would like some reassurance about is that we are making sure that our children, our looked after children in particular, are getting all those key points that they need to, and how, if you can share sort of how you as the manager of that particular area are doing it. And Mark, the same from you. Again, I don't expect an answer now. I've realised that you've been asked to sit in basically, but again, it's making sure that we've got that good programme going within our care home settings in particular, and those vulnerable people at home receiving domiciliary care, that we know that there will be a plan. And again, that can come back to me later. I'm quite happy, but I think this committee needs to know that those two vulnerable groups are being cared for. If you want to say something, you're welcome to. If you want to just say, I'm going to go home, go away and think about it, it's up to you.
If you don't mind, I'll go first. As far as care homes and supporting community supported living domiciliary care, there is very much a robust plan in place, and that's been in place since COVID and was developed as part of the COVID vaccination programme. So there has been reporting that has to be done through the capacity tracker nationally on vaccine uptakes in care homes and supported settings. That level of reporting is dropping back now, but we're carrying on that good practice. Every time there is a campaign around COVID vaccination or any other vaccinations, we're pushing that out through all of our commission services and sharing that information with the services that we don't necessarily commission with, but we know are provided services out there.
Well, thank you very much.
Particularly for our looked after children, the conversation is always on the agenda with the foster carers who are offering that care, to really emphasise that those immunisations are important, those appointments are scheduled in as part of the looked after child reviews that happen. The IROs who support and are independent in reviewing the progress of the plans for our looked after children also address what's happening when it comes to the progress on their health needs. So that is always on the agenda for our looked after children also.
Thanks very much indeed. Julie, you want to come in?
I just wanted to build on the points made there about the adult social care, that the outreach team also look to go into spaces and places that to try and reach all those parts. So for example, they might operate a bespoke session for carers. We also go out for our complex lives into spaces that they can find easy access. So I think there is a very robust process, both in terms of routine, getting into the care homes and the adult social care system, but also finding spaces where you know, so those other groups might be that we need to reach as well.
Thank you. Sue?
This might be a naive question, so it's probably a question to Ruth. I've just been away on a course, and you'd never send a member away on a course because they come back with all these questions. So I'm looking at page 42, and there's two lines there which are very small, but the way I am interpreting them, because I've just been away on this course, is huge. It says, inclusion inequalities, protect the health of people experiencing greater inequalities in health or access, implement the inclusion health agenda through health protection systems. There's a lot of jargon in that. So I'm going to ask a question. So having been away and having this wonderful public health advisor on my course, telling me that use it or lose it, get people moving, active health is the magic pill that if we could give it to some of the people who live in our more deprived, less healthy communities, if the NHS could pill it, they would use it, because the NHS, these are her words, are more used to dealing with people who are sick than stopping people becoming sick in the first place, which is where public health comes in. So with those two little lines, where can we have a conversation about having really direct, so following on from the questions you were asking, Kathy, about the falls, you know, stop people falling and you save in impact further down the line, where can we have those conversations where we can look at a specific health outcome? So I was talking about diabetes earlier today in some communities. So where do we have that conversation where actually if we took a little bit of money out of the NHS and put it into preventative work and put it into, I don't know, more social subscribing, directing people to gyms to stop them getting the diabetes in the first place, or to prevent it escalating to a higher thing. So where does that conversation?
Anybody that speaks to me, basically,
Right,
or,
I thought it was
any
going to
of
be
my
you.
team.
Yeah. No.
Yeah,
That's
and a lot wider than that,
Yeah.
because I think there's a whole, you know, most people understand the public health agenda. I mean, Nicola over there's Masters in Public Health, fully briefed on, you know, what we're doing. The programme that you mentioned was paid for through the Shares funding, so came from ICB funding, I believe, that one. Many of the programmes have been supported through bits and pieces of money that we have found as a system rather than necessarily the specific public health grant. And one of the things that we do in public health, but working with partners, is look at all the different groups that might have particular benefits if we could get them to be more physically active, better enabled digitally, linking into our wellbeing hubs, all of those sorts of things. And trying to specifically understand who should we be targeting and how do we do that. And obviously in Plymouth, our wellbeing hubs is one of our really big routes to doing that, because they're out in communities, working with communities. We commission the health improvement team from Live Well, who physical activity is one of the focuses of Thrive Plymouth. So they are out there talking to people, leading walks, getting people who perhaps wouldn't normally think about going for a walk to just have a little mooch around the neighbourhood. And obviously in the council, we've got huge numbers of schemes around, as you know, around how to use our green spaces and blue spaces more effectively and how to get more people. Some of the interesting stuff we've been doing at Inside Lido has been finding groups of people who would not normally want to go into a swimming pool, let alone an outdoor swimming pool or the sea, and giving them the opportunity to do that in a place that is in a situation that feels safe to them. So yeah, absolutely. I think it's fair to say it's something the system are pretty passionate about, but it's always difficult to find the funding to do that, as you know.
So perhaps not now, but I'd like to pick that up with you afterwards if we can, before you leave today, because it's an area that I think there's a great opportunity for the city, which I knew it was going on, but I didn't know where the discussions took place. Okay, thank you.
Thank you. Appreciate that. So everybody contributed, thank you very much. And I've been very remiss for item 5, 6 and this one. I should have been asking you to note the reports and consider further actions, whereas I think we've been doing the actions as appropriate as we've gone along, but I didn't ask you to note it, so thanks. Okay, so Julie, thank you very much indeed for coming along. It's always useful to listen and to hear and catch up with what we've been doing. So, Kamal, the task is now yours to present us the paper on Plymouth Drug Strategy Partnership Annual Report.
Thank you. Yes. Hi everyone, I'm Kamal. I'm one of the consultants in public health and I lead on the drug and alcohol services in our team, which we commission, and I will talk through that now for you. So this is the annual report of the Plymouth Drug Strategy Partnership, covering the activity in the calendar year 2023. I will talk through the background of that as part of this presentation. First thing to say before we get into anything is we always put people at the heart of everything we do in this arena. So I really wanted to start by talking about the people who we are trying to support in this environment. So people in drug and alcohol services, really do have a really unique lived experience that's characterised by, in general terms, some of these features, which include multiple disadvantages, including poverty and deprivation, high incidence of significant adverse childhood experiences and trauma, and often experience of exploitation and abuse. So people in drug and alcohol services also have generally overlapping experiences of homelessness, substance use, poor mental health, and offending. And there's a very clear kind of Venn diagram of overlapping issues there. People often experience significant experience of stigma, and there are, talking about inequalities, big inequalities in people who inject drugs who are 13 to 17 times more likely to die prematurely than the general population. So in 2021, the previous government, and I prepared these slides before, so I have added that, the previous government's drug strategy from harm to hope was released following a prolonged rise in drug-related deaths, and also following a two-part review by Dane Cowell-Back. And it asked each local area to form a local combating drugs partnership to bring together different parts of the drugs work, including breaking the supply of drugs, so on the enforcement side of things, and then delivering world-class treatment and recovery systems, and looking to bring that shift in demand for drugs. So accompanying that strategy, there was additional funding for the substance use treatment services. That funding has been is quite significant, as you can see in your papers, but does follow a period of 15 years of reduced funding over time, and so it arguably it makes up for, or doesn't quite make up for, that level of funding, but it has come, and we've been using it as I'll describe in this presentation. So the majority of the funding that we have from the Supplementary Substance Misuse and Recovery Grant is delivered through the Plymouth Alliance for Complex Lives. So that is an alliance of 7 core organisations and over 20 subcontracted organisations that work together in the areas of mental health, housing, and substance use treatment services that have a devolved budget from public health and community connections in the council to work as a system to support these people and support the whole, we say whole systems approach for whole people, support them as their needs, and not just individual silos of their needs. And the money really is to improve the capacity and quality of treatment and recovery services, following a decline in that over the years. So looking at the why it's important that we do this, and you look at the person in it. If we are supporting them in a treatment and recovery system that is effective, we improve their life and well-being, we reduce their risk of death, we reduce their risk of reoffending, we support them to move towards stable accommodation and employment, and it improves the lives of the people around them and close to them as well. To society, it's a huge impact to society. If we engage more people in our drug services effectively, we reduce the demand for drugs, we reduce associated crime with drugs, homelessness, antisocial behaviour, drug paraphernalia in public spaces, and the research shows that For every £1 spent on drug treatment services, it saves another £4 from the wider system, including health, prisons, law enforcement and emergency services. And over 10 years, that increases to over £20 for every pound spent. So it's really important work. So the Plymouth Combating Drugs Partnership chose to be called Plymouth Drugs Strategic Partnership. And some of the principles that we've adopted is some of the things I've talked about here, which is to be trauma-informed and compassionate, to work as a whole system, to reflect the complexity and the scale of the challenge, to be based on the lived experiences of the population, to focus on prevention and to reduce inequalities, as you'd expect from public health. So we undertook a needs assessment in Plymouth on people in the drug treatment system and people who use drugs in general, and we found that people in Plymouth typically presented with polydrug use, so more than one drug use, including alcohol in that, tended to be older and more complex than the national population in terms of people who use substances and services, and therefore actually spend longer in our treatment service than nationally. Our treatment services are really good at reaching people who use opiates. So if you look at the estimated prevalence of opiates and the number of proportion of those that are in our treatment service, we've got the 4th highest rate in the country for that, which is really promising. But we have focused on opiate use, and actually our levels of people who use crack and alcohol have been relatively low in terms of represented in our treatment services. But that is similar to national averages as well. But and just to give some numbers on that, so about 62% of people who use opiates are in our treatment service. Nationally, that average is about 40, and about only 20% of people who use crack and alcohol in our treatment service, which is about similar to national rates. In terms of in our treatment service, 66% of those people are male, the rest being female. So over the course of the year, in 2023, the number of people in our treatment service increased from 1,730 to 1,940, so a significant increase. In the papers, most of that has been increases in people who use alcohol and crack, which reflects the kind of unmet need that I highlighted on the last slide. In terms of drug deaths, we know that drug-related deaths are higher in Plymouth than nationally. That reflects kind of the increased deprivation and complexity that we see in Plymouth, and the age as well in terms of people who use drugs in our system. And there's two kind of related figures here. There's deaths in treatment as well, which is the number of people who are in our treatment system who die within a year of being in that treatment system, whether that be from drugs and alcohol or any other cause. It could be any cause. And so I put there that the percentage of people who die in our drug treatment system in a year is 1.69 compared to 1.27 nationally. That's come down again for us from into 2024. So things are improving. As you can see, numbers of deaths in treatment, not just as a percentage, but actually as an actual number, has been reducing over time when nationally those figures are increasing or stable. So we're still above the national average, but there is progress being made. We looked at the deaths of people who were in our treatment service and did some analysis, and generally found that about a third of those deaths were not due to drug and alcohol, but due to physical health conditions, often at an earlier age than you'd expect, but conditions like COPD or cancer, and then the other deaths due to drug or alcohol, more drugs than alcohol. So in last year, there's been a significant amount of service improvements in terms of those drug-related deaths. So there's been an upskilling of the wider workforce in harm reduction and naloxone. So harm reduction is things like needle and syringe programs, and naloxone is an antidote to a opiate overdose that you can use in those situations. So we trained a lot of people, including in our hostels. One of the key areas around a lot of those approaches. UHP give naloxone on discharge from hospitals if someone has come with an overdose, one of only 3 hospitals in the country to do so, which is really great. We've introduced a rapid access to prescribing team and a Plymouth overdose response team, so people who are identified as having an overdose can be rapidly entered into our treatment services, have a rapid assessment and rapid opiate substitution therapy, so methadone being the most common medication that we use to support people to not use injectable heroin. We've been looking at optimizing our doses of opiate substitution to reduce the amount people might use on top, and we know that if you optimize the doses, then people don't use on top as often, and so we've been doing a lot of work on that. Just by the extra funding, having more drug and alcohol workers in our system mean that each drug and alcohol worker can have less people on their caseload. Before funding, they were operating at around 80 per person, which is, the national review saying it should be around 40. So we're approaching that at the moment because of the increased workforce that's been able to be employed. And also we link well with the Health Inclusion Pathway Plymouth, which is led by Live Well, and really looking at that. That's looking at the the homeless population and the interface with secondary care, looking at admission avoidance, supporting people when they're in hospital and planning discharge. So there's really good overlap between what we do and the HIP team. We've also improved treatment for people who use crack and doubled the numbers of people in treatment so that they can access that support. One of the really key areas is prison leavers. So people who leave prison with substance use needs are referred to community treatment service and picked up in that community treatment service within 3 weeks of discharge. Traditionally, those figures in Plymouth have been relatively low, and we've been doing lots of work to increase that, and it's approaching now the national average in terms of that particular statistic. And there's also work going on, which you'll hear about next, on vaping, part of what's happened next anyway, on vaping of illicit substances, particularly by children and young people, and the partnership response associated with that. So looking forward into this year, there's the work's ongoing. The grant funding has enabled increased capacity. So the grant was delivered as 3 years. So this is the final year of the increase in increments. So we're expecting it to be stable from now onwards. So we have managed to increase capacity of our system, both in terms of drug and alcohol workers, but also things in recovery, children and young people system, mental health support, all across that those range of needs. We've developed a local drug information system, which is able for people to report intelligence about potentially adulterated, new, potent, or contaminated drugs, so that we can respond quickly by providing that information out and understanding that. So we formed a partnership with the police, providers, medics, and public health in order to assess any information that comes to us about batches of drugs that might be concerning, and test that, and plan a response with our partners. So I put testing there as well. So a partnership's been formed with Bath University to test drugs, so we know what might be in drugs, so we know what we're dealing with. Previously, the police testing capacity would mean that the results might be 9 or 10 months delayed, which isn't useful. Bath University can now test drugs within 24, 48 hours for us, which is really, really, really useful. We've been improving on naloxone distribution around the city. You might have seen on news or social media around peer-to-peer distribution of naloxone, which is really engaging more people than we can reach in general. And the police are also now going to carry naloxone in their first aid kits, having not done so previously. We've implemented an avoidable deaths approach, which is implementing learning from deaths from drug and alcohol. So it brings the partners together to review cases, individual cases, and identify learning from each case that's going to be shared and lead to improvements in how we provide our services. Continuity care work, which is the from prisons to community treatment, is continuing, and there's significant support for a continuity of care working group there. We are improving our alcohol pathways. There's a new alcohol support team at Harbour, our drug and alcohol services. We're looking at the children and young people's approach. One of the key elements is around workforce development. So the part of the process of the alliance is really to ensure that no one front door approach. If someone comes to the homeless service, they can be really, have all their needs discussed and assessed at that point, rather than say, okay, for your drug stuff, go to the drug service for you. So that's the the cornerstone of the alliance approach, and workforce development's been identified as a key element to support that going forward. And finally, we've also been working with SWAS, so the South West Ambulance Service, so that they can refer in people who they see with overdoses into our treatment service, so that we are getting as many people as we can into our service, and we know the benefit that has. That's it. So that's, happy to take any questions.
Thank you, Kamal. Very informative. So, anybody got any questions? Patrick?
Thank you very much indeed for the presentation. Just on the cohort in Plymouth, what percentage would you say are Indigenous local people, and how many drift in and out of the area? So, people, some of these people are transient, aren't they? So they come to Plymouth and then access services. So what percentage would you say would be local people and stay local, and those that flit in and out of the city? And generally, sort of following up a bit on the previous topic that Councillor Dan raised, what are we doing to prevent or to encourage people not to take up drugs in the first place? Thanks.
So on the point about transient community, I don't have exact figures. It's very obviously difficult to know, but we do know that actually the drug community in Plymouth is a bit of a community, so it isn't probably as transient as we might think, and that was one of the reasons why actually we have so many of our opiate users in treatment, is because they talk to each other and they know actually that what Harbour offer is a really good offer in terms of support, and Harbour have worked really well to build those relationships. So I don't know for sure, but I know actually that there is a community. And then in terms of that prevention work, so prevention of drugs is everything. So one of the key risk factors is as we talked about, is poverty and trauma, especially in childhood. So all the work that we do to reduce inequalities in the city is reducing future drug use. And all the work we do in the trauma-informed approaches that we take, the schools, and that kind of mental health support in schools is prevention for drugs. So it's and then we do have particular going slightly more towards treatment than early prevention. We have partnerships that we've built over the last few years, but based on long-standing relationships around support for children and young people who have been, for example, vaping illicit substances, as really increasing that support through additional workforce. So this year we've got 5 extra posts that are focused on children and young people in our system, so that they can build that approach, go into schools, support the people who have been identified as needing it at an early stage, so that they can get that support at that point, and that will obviously have preventative impacts as well.
Thank you very much, Kamal. Thank you.
Thank you. Cathy?
Thank you. I've got a couple of questions which may or may not be related. But Plymouth people appear to present a little bit older, you say. What sort of age range are you talking about, and what sort of drugs does any particular age range use? That's my first question. Secondly, with regard to premature deaths, that are not apparently from drug use, how much could drug use have contributed to those earlier deaths? For example, cancer or heart failure. Thank you.
Thank you. Yeah, good question. So yeah, so in terms of the age range, if you look at kind of particular, I don't like the word, but heroin epidemics in the country around the 80s, and so we know that actually the people who use heroin or opiates are generally in their kind of 50s or older, and so actually kind of that is related to that next question, which is their biological age, given their their history, which includes drugs but also alcohol and smoking, is a lot higher. So so as you said, it is contributing to it. But it wasn't the primary cause of death, essentially, in the ones that we looked at. But it's very likely that it would contribute to early death, yeah.
Can I just come back on one point? Is there a particular sort of drugs that people have at certain ages? Is alcohol more likely to be in the the drug use of the older people, perhaps, or opiates or whatever?
Yeah, so generally opiates are the kind of middle age population in Plymouth, and younger people might be more likely to use things like what might be more likely to smoke heroin or crack, cocaine, or other drugs like ketamine as well, and spice, as you might have heard. Those are more towards the younger end of things. So you generally get less new IV heroin users in the younger population than the kind of people who have been doing that for a long time.
One of those things that we were picking up is obviously we know more pharmacies are closing at weekends. So if somebody's on methadone treatment, etc., how are we making sure that they are getting their treatment at the weekends, or are we finding more are going on a Friday and having to then be given 3 days worth? And are we noticing any problems arising because somebody's been given 3 days worth on a Friday? And that's obviously something that's been happening particularly over this last 12 to 18 months. Are we beginning to gather any information on that?
Yeah, so interesting actually that one of the things in the COVID pandemic brought up was that given access to everything was reduced in COVID, was one of the all clients were risk assessed on how often they need to go into a pharmacy and collect their and have a directly observed treatment, and actually in lots of cases we're able to reduce that and reduce that safely, so it's actually going less often on a risk assessment basis and a monitoring basis actually didn't lead to any clear adverse problems. So actually we know that many people can work quite well in that way, but it's done on an individual basis, and the main there are there's lots of pharmacies in the city, and a smaller proportion of those deliver the supervised consumption of opiate substitution therapy, and they are generally more available at the week, well, Saturday at least, in general, those pharmacies. So there is a bit of kind of matching the demand as well in that respect. Yeah.
Thank you. Sue, did I see your hand up?
I don't normally ask financial questions, but on page 97 at the top, or 9 of 11, you've said there will be a total of 2 million, blah, 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 an additional over 1 million from the previous year. So as this is a funding plan leading up to 25, my question is, why did it virtually double in a year? Because that's lovely. I don't know what magic formula you've got there, but it's certainly not in my budget, is one. And number two, what's the sustainability of this if this is a 3-year programme? Because that is a massive increase in funding.
Yeah, so that happened at all areas got this additional funding. It wasn't something that we all areas nationally got it, and there was some element based on need. So Plymouth got a high proportion for our population compared to, say, for example, Devon. So that it was set nationally in the spending review previously how that money was going to be distributed. So as you say, yes. So in our first year we got around 700,000, and then 1.2 million, then 2.4 in this current year. So as you say, that's additional 1.2 of new money compared to what we put in place from last year. So so that's just how it was delivered from the grants team in central government. And in terms of sustainability, it's there is a level of uncertainty, because there's a level of uncertainty in all funding, because the comprehensive spending review finishes at the end of this year, and the new government haven't yet had a chance to do their comprehensive spending review. From speaking to colleagues in the National Joint Combating Drugs Unit, you can't count chickens. It's very unlikely that this funding will change significantly in the time going forward, because the whole point was to build a workforce that had been depleted over time. And so it's very unlikely that that's going to then, after 3 years, then just say, okay, back to baseline, and you've built a workforce up. That's still trained. We're still developing that workforce, because a lot of people have only just started. So it would feel very difficult to stop that, but we haven't got confirmation, because no one has confirmation yet.
Well, we know there's lots of financial pressures across all systems, so not just local authorities, but within the health service as well. But I think that, can we just have that noted as a risk, and that when we do our asks, whatever system the funding comes in through, we highlight this as a risk, because what you wouldn't want to do is build up all this fabulous support to support all these people, and then all of a sudden for them to fall off the edge of a cliff because it stops. Thank you.
Thank you.
Well, thank you very much indeed for coming this afternoon. I'm going to ask you to note this report, and Sue, thank you. We'll make sure that point you've got is there for further action. Okay, so thank you very much indeed. Okay, right. Dave, sorry to have kept you, but it's been a really a good afternoon that we've had lots and lots of questions. Before you settle down, I'm going to ask Terry, do you want to come up and sit at the table? And I obviously the councillors are very much aware this is something that was very close to your heart as well. Yeah, you might need to share a mic with Patrick, so I'm sure we can manage to do that. So, okay, Dave, the floor is yours.
Okay, good afternoon, everybody. Dave Schwartz, Public Health Specialist. Okay, so I'm going to talk to the paper here and refer to the paper you have in your pack. A very brief background. Vaping position paper was approved by the Health and Wellbeing Board on January 10th, 2019. That's on Appendix B in the pack. This was reviewed on September the 14th, 2023 by the Health and Wellbeing Board. And a key area of concern was identified as being around the increasing prevalence of use by young people under the age of 18. So between 2019 and reviewing in 23, we had seen quite a significant increase in reported use by young people. The board agreed to establish a working group involving a wide range of partners to look at agreeing an approach to children and young people and vaping, and report back. And this is that. And I'm going to note that just Councillor Beer actually took a motion of notice to this full council as well on in September 23, which also referenced this work as well. As a result of that, vaping working group was pulled together, and a meeting was held on the 23rd of May to explore issues around children, young people and vaping, and how city partners were responding. The report sets out the findings of that with recommendations. The working group received presentations from OHID. We had a colleague come down, and they covered issues around context and relative harms of vaping. Ourselves from Public Health contributed through looking at Plymouth issues and responses, and we also had trading standards looking at enforcement approaches. We also were able to review a report from the Plymouth Youth Parliament that looked at vaping as well. Following that, there was focused discussions, and from those discussions we captured the key points which fed into the report, and also the recommendations. And the recommendations or actions are in Appendix E. It was noted that over the last 12 to 15 months, there has actually been a significant amount of activity in terms of partnership activity, both in terms of prevention and response to vaping across the city. And that has meant that we've been able to provide quite a lot of information, advice and support, as well as enforcement. Subsequent to writing the report, I've actually got a survey back that we undertook with all the secondary school system. And I suppose the key points around that is that the secondary school system have valued all of that support and partnership, with significant references to the advice and guides that we provided, the access to services like the specialist treatment service, and also the opportunity to actually raise awareness of vaping as a substance use across the whole secondary school system as well. So we've had a number of different opportunities to promote that with them, and we offered monthly meetings to the secondary school system all through the last academic term. Just before noting the recommendations and then opening up to questions, I did want to note that in the King's Speech on July the 17th, it was confirmed that the Tobacco and Vapes Bill would be an early priority for the new government. And this bill will reduce the availability of vaping products by regulating the flavours and contents of vaping products, so it'll be restricting that. It will be, let me just take my bulldog clip off. Thank you. It will be looking at the regulation of packaging and product presentation, rather like cigarettes, and also point of sale displays, so how they're actually displayed in shops. It's also worth noting that the bill will also introduce on-the-spot fines for underage sales of tobacco and vaping products. There'll be a 30 million fund, which is a national fund distributed across the different areas, going to different enforcement agencies, including trading standards, to help enforce underage sales at local level. And also, interestingly, I think this is quite interesting. Government will also be working to enhance online age verification, which will be quite an interesting exercise, I think, to see what that actually looks like. So that will be looking at how you can restrict access to vapes and other tobacco products online, based on the legal age of being able to access those. So in that context, I think the recommendations that we've come forward with sit within that kind of larger central government approach that's being taken now. So we're asking that the Health and Wellbeing Board notes the outcomes of the vaping working group, that the Health and Wellbeing Board endorses the actions set out in Appendix E, and that the Health and Wellbeing supports ongoing citywide partnership working to prevent uptake, minimise harm and respond supportively to the issue of children and young people vaping.
Dave, thank you, and thanks for leading that. And certainly that day or the morning was really, really informative. And certainly listening to there were a couple of young people there, and they were very, very balanced, but very firm in what they were saying, which was really useful. Tony, you were present as well, weren't you? And Sue was there. Do either of you two want to come in about that vaping morning that we held? Sue?
It was really interesting. I think the sad thing about it was that there wasn't enough representation from the schools. And we are aware that in terms of schools, issues with vaping in schools and the effect it's having on exclusions and behaviour of pupils is still great. So I think the work that Dave has done has been very timely, because I think we've been able to, as an authority, give out some really good advice to schools about how they manage their discipline around vaping. And I also think what isn't in here as well, or I can't remember reading it, is the effect on, well, litter. I don't know if you've been up to the box lately, but there's an amazing modern sculpture of 4,500 vapes that Clean Our Patch, one of our litter picking groups, have picked up, just to raise the fact that it is very, very disposable. So I think anything that we can do to regulate the sale of it in the first place, especially to young people, can only be good. So this is a very opportune piece of work, because it's pulling in lots of strands all together.
Tony?
Yeah, I think I would echo everything that Sue's just said, but I think from a Health Watch perspective, it's not very often we get involved in something like this. We're more about services and the issues with services too. So to come into that environment and listen and take in everything that's going on around that sort of topic, how it's affecting young people and the work that's going on in the city was quite enlightening from my point of view, and I welcome that. So,
Terry?
Chair, I'd like to thank everybody who worked on this report, because it's just an amazing piece of work, and I'm delighted that I was able to bring this and highlight this in our full council meeting, and we were able to debate it. Dave, one of my questions would be in around how many senior schools did engage, because picking up on the point that Councillor Dan was sharing with us just now about behaviours in school, vaping in school, and the impact that that's having on education and exclusions, I wonder how many of our senior schools across the city of Plymouth have actually participated in engaging with you. Thank you.
All of them.
That's good.
Yeah. So the survey we ended up we went out to 20 because we included some of the key stage 4 schools only. We got 19 responses, which is really good for a survey. But actually, in terms of the overall piece of work, everyone engaged. But I think it would be fair to say that some schools engaged more than others.
And unfortunately, we had nobody come on the day because of various reasons. And we certainly, I met a head teacher at something else a couple of days later, and she was very apologetic that she hadn't been able to join us. But Dave was then able to at least say that he had gone out, and that engagement will not stop. That engagement will carry on. Dave has made those links now, and we will be making sure that we follow through. And so, I mean, from my perspective, what I need to be absolutely sure is whatever is going on in the King's Speech then goes through Parliament, and what comes out. And it isn't just from a health perspective, it's obviously the trading standard side of it, and that's Ruth's department as well. So it keeps that holistic look at it. And certainly I'm sure from a children's point of view, there were quite a few members from Children's Services at that work day, and so it's good. Michael Howes was there, and he's that link between us and schools. So we've got that ball rolling, and it ain't going to stop. You know, Plymouth is built on hills, and that ball is still going to roll for quite a while. So
I'm
Dave,
delighted to hear that, Chair. Thank you.
Then I'll go back to...
Yes, I was going to say it's just picking up on some stuff that Kamal kind of referred to in terms of the additional funding into the city. So what that means is that we have 2 full-time equivalent workers, one based within the youth service, one based within the young people's treatment service, whose role is entirely focused on vaping. They will prioritise probably those that are vaping substances controlled under the Misuse of Drugs Act, but they will be adding a lot of value to the system in terms of being able to link to schools around vaping in general. And we've also got resource at the zone that's being funded and we're just finalising. I mean, this is going to be the outcome, so I'm not going to give anything away. But what it will mean will be that every single pupil in Year 8 and Year 9 in every single school will receive sort of drugs education linked to vaping in the school for over the whole of the next academic year.
And habits as well.
Yeah, so yeah, HAMOs are involved, the zone are involved. So we've got good resource now, which we never had. And they will be targeting the population that we've particularly seen are the group that's been kind of mainly the ones that have kind of engaged with vaping that's caused us most concern.
Terry, do you want to come back and then Patrick?
Well, just really to reiterate what I've said this afternoon, I've got 2 vape shops in my ward, and they are like walking into sweet shops at the moment. They have flavours that you could never imagine, and I think that any new bill that's passed through Parliament that changes that will be a bonus to us all, and hopefully we will have a clearer picture of the impact of vapes having on not just children and young people, but also the adult population in the very near future, because we don't know what the impacts of vapes are in comparison with the fact we do know what cigarettes do to people. So I'm delighted, Chair, that you're going to keep this on your agenda and that your finger is well and truly on the pulse, because I'm not going to be here forever, and I want to make sure that everybody in Plymouth is healthy. Thank you.
And that's where it's important that this board lays those lines. And certainly I'm sure Amanda and the hospital are, through your clinics, etc., chest clinics, etc., that will be something that you will be monitoring and keeping it. I mean, as we say, there's no facts or yet that say what harm, if any, vaping does for an adult. So I think it's really important, isn't it? And those stats will be coming in over the time, Dave. So, we're going to keep an eye on everything.
It might be worth just noting that we've got a really good relationship with the safeguarding nurses at the hospital, so we liaise a lot. So if we ever have a presentation, we can work that through. And the other important element of that is that we, I can't emphasise enough the importance of prevention messaging being credible, because issues around drugs or alcohol, and to some degree vaping, can just take off. And if the messaging doesn't make sense to the people we really want that to engage with, then it doesn't actually really work. So we kind of triangulate with the safeguarding nurses around what they see. We do that with youth workers around what they see. We pick it up from the police, and we create quite a useful package of information that the young people have told us kind of makes sense to them.
Patrick.
Thank you, Chair. Well, I wanted to pick up on the recommendations a little bit, in that whilst we acknowledge the outcomes of the working group, I think we should record as a board our appreciation and thanks for the work of the working group in doing expeditiously all that you've done really since this issue has come to light. And the significant concerns that the public have had have been recognised by the local authority and our key stakeholders. So I think, Chair, it'd be good to acknowledge that in the recommendation. Sorry if I'm looking a bit dense, Elliot, but we refer to Appendix E. Is Appendix E what is pages 137 and 138?
I don't think they were numbered that
because
well. Yeah, 137 and 138.
Yeah, yes. Yeah, it's fine. I just want to know what I was going to be asked to vote for. Yeah. But no, absolutely. I appreciate all that's been said, Chair, and I think it's important that there is some member overview, in the coming years to this work, and making sure that we try to safeguard really the general public at large, and particularly young people who tend to be the vapors of today, from the potential harms of the future. As Councillor Mrs. Beer has mentioned, we don't know the impact of this, a bit like we didn't know the impact of asbestos in the workplace. We didn't know really the issues of smoking, probably when the cigarette was first invented. So I think, this is an important piece of work, and I congratulate Dave and all those that have been involved. Thank you, Chair.
Thank you for that, and certainly it won't be going off the agenda at all, whether it's here or whether it's in scrutiny, and I think this is where we need to liaise with the chair of scrutiny. And Vice Chair
And
is
Vice Chair,
scrutiny.
yeah,
Yes, yeah. So, you know, it's going nowhere very fast, but the energy that is being put into it, I think it's wonderful to watch, and certainly anybody that's got a health hat on will be looking at that King's Speech very carefully, and then government enacting of whatever they come forward. And we will keep that on the agenda, have no fear. All right, so thank you, Terry, and thank you to all of us. So, without further ado, Elliot, are you going to give me a fourth bullet point for those recommendations, please?
Yeah, thank you, Chair. If we can just have a propose a second on vote on the addition of Councillor Nicholson's recommendations, which is to record appreciation and thanks for the work of the vaping working group and partners involved.
I'll propose it, Chair, as I said it.
Lovely, thank you very much indeed. So, do we all agree those four proposals? Yep. Excellent. Thanks very much indeed. Right, folks. Cool. We finally caught up with ourselves. Nearly. Not quite, but nearly. Tracking resolutions. Elliot.
Thank you, Chair. Just like to introduce Karen, who's joined us online. Just see if she can, there she's there, perfect. So I'll just start us off. The first recommendation was requesting a breakdown of reasons for medication shortages and delays. So that's complete. The link is attached if you're viewing it electronically, and it's also being shared with members. The second one was that we delegated to the Chair of the Health and Wellbeing Board to submit the final survey response to the Devon Community Pharmacy Strategy. That has been submitted, and now Karen is here to tell us about the next stage. Thank you.
Karen, thank you for joining us.
Thank you for inviting me. So don't worry, I'll be very quick. So just to say, the public engagement survey for the development of the community pharmacy strategy is now live. It was delayed slightly by the election, but it's now live. And the results will also inform the revision of the pharmaceutical needs assessment, as we've included a number of questions that are required as part of that public engagement for the pharmaceutical needs assessment. The main public engagement events with Healthwatch are likely to be the 14th of August, and I think it's going to be a collaborative approach across Devon, Plymouth and Torbay. I think, Elliot, you've sent links to the public engagement survey, haven't you? If not, I'll send them to you after the meeting.
Yeah, through you, Chair. Members should have received that link. If you haven't, let me know.
Okay, lovely, thank you. And so this update is quick, so I'd just like to thank the members of the council and the public health and health watch teams for their involvement in developing it, because it's been very comprehensive in its development, so thank you.
Thank you. I think considering how many concerns there have been, as you say, that was why we felt the pharmaceutical needs assessment needed to be brought forward slightly, because we had concerns. So I think that it's even more important that since we started to stir it up, we make sure that we put some good responses into that. So we will get active on that. Thank you very much indeed for coming along to that.
Thank you.
Elliot, the rest.
Thank you, Karen. Thank you, Chair. So I'll just go through the remaining actions that are in progress rather than the complete ones. If members have any questions afterwards, please ask away. So the first one that's in progress is for a councillor briefing on suicide prevention and awareness training to be provided. Been in touch with Kamal, and we're organising that as part of the package of new induction training. We will open that up to all members and we'll confirm a date with you shortly, but that is in hand. There's just an awful lot to get through. The second one is from the 24th of the 1st. This one is only marked part complete as the Health Watch Carers survey is still being finalised. Tony will confirm. I'm getting a nod. So as soon as that one's sent out, we can mark that one as complete. The next one that is complete is part complete, sorry, was to request future reports from NHS Devon, request updates on 111 and pharmacy. Obviously, we've received that today, so we can mark that as complete. But we've now received an action for that to be in more depth, so we'll put it back on there. And that is the end of the part complete ones, Chair. Thank you.
Elliot, can I just check the one with the 7th and the 3rd? You've got down as Pauline.
Yeah.
Are we saying it's the Health and Wellbeing Scrutiny Board, or is that this board? Because if so, it's not Pauline, it's me.
Yeah, apologies, Chair. With both items now being called health and wellbeing rather than health and adult social care, that should be yourself.
Thanks, I was getting confused then, I must admit. So yes, the change in name of the health scrutiny is not made life easy at all. So I think maybe we have to think about whether we can change it somehow to differentiate. But we will tackle that with Ross, I think. Okay, folks. So that brings us then to the work programme. So I'm going to go for the board to consider any items they want to bring forward. We've got a meeting in September when we're looking, then there'll be the Plymouth Plan and the Peninsula Acute Sustainability Programme draft case for change. Nicola, have you got any, can you shed us any light on that acute sustainability programme? Or am I being cheeky and it should be Chris then comes back to us to tell us the...
Through you, Chair. That one has been to the most recent health scrutiny. They've also asked for it to come to the board. So I will check in with them and confirm that's still good to come, but it's a slight different angle from what went to scrutiny recently.
Yes, that was quite an interesting paper. Patrick, did you see, were you, no you weren't, were you?
I've given up
Sorry.
my place on that, unfortunately.
Yes, it was quite a mind-boggling paper, if that's a correct phraseology. So I do think we need to watch what's happening, but it was talking about centering certain things in certain places, and I just think we need to watch that one very carefully. Idealistically, I can understand it, but practically, I'm not so sure. So I think we won't let that one off the radar. And of course, things can be changing. Yeah, you know, this was done planning up to the election. So in fact, there could be more things that come out now with the King's Speech and what is happening within the new frameworks for NHS stuff. So I think we don't want to let that one go. Tony.
So on this subject, we've been approached by NHS Devon around some public engagement. Early days, no real details about what it's going to look like or time frame, but I suspect that will tie in with this coming through the system.
And presumably you will want to bring your report, won't you, that your annual report to somewhere. And I'm not too sure whether that goes to scrutiny first or and us to informational as to how we deal with that, because I know your report was held up because of the pre-election period. I'm trying not to call it PERDA, but pre-election period. So I think we need to make sure that we don't lose that sight of that report.
Yeah, I think in the past we've taken it to overview and scrutiny.
I think it won't do us any harm for this board to at least be sent a copy of it so that we can, which I know you sent me one, so I do appreciate that, but I think the rest of the board, it would be useful for. Patrick?
Thank you, Chair. Just two things. Just on the Plymouth Plan, is that an updated Plymouth Plan, Elliot, or is it a review of the Plymouth Plan? Because we're going to be reviewing the joint local plan, and the Plymouth Plan and the joint local plan were generally in tandem with each other. So just a clarification on where what we're doing.
Yeah, through you, Chair. I'm not aware that that was an update or a new version. It's more sort of the backbone of what the board should be considering. We work very much off the Plymouth Plan and the Joint Strategic Needs Assessment. So it was bringing that in. It wasn't a finalised item, it's there for suggestion, but relating the work that all partners do into that plan, how is it performing? So not a new version as far as I'm aware.
Okay, because at some stage, Chair, we're into this review period on the joint local plan, of which the Plymouth plan might need an update. So we might want to investigate the timing of this coming, because it's a bit pointless reviewing something that's going to hopefully come to us soon after with potential updates. So that's just a bit of, just to take on board. The other one that I wanted to raise, as one of your predecessors, I did raise in confidence with Ruth at the time about fluoridation of water and potentially having a sort of council discussion on its merits. I wondered, with the ongoing issues of dental health and the impact of sort of decay, whether fluoridation is something that we as a board should have a paper on at some stage, because there are powers within sort of local stakeholders and the authority to push this if it's felt that there was a local consensus. But it is, I know, double-edged sword. There are those that are against it and those obviously that are. But I wonder if it should form part of our work programme in this municipal year.
Yes, I think that would make a lot of sense, and there were a lot of issues around trying to do it as a local authority because the boundaries just don't match the boundaries of the water flow. But my understanding now is it isn't in our control. It's a Secretary of State decision, which actually does make it easier to do it across multiple boundaries. So I think that would be something really useful for the board to at least review and draw a conclusion or form an opinion on.
I think that would be a good thing to do, because certainly from the Dental Task Force point of view, it's one of those things that, should it be considered, it has one of the most impacts on teeth. It's as simple as that. So I think, yeah, and of course we have fluoride varnishing as one of the things that we do, and the value of that. So I think it could well be a prudent thing, and that will certainly be before the next Dental Task Force meeting, because I think we're looking at October for that. So in fact that discussion to have would be very useful.
Through you, Chair, I will have to take that one away and have a look at it. I'm concerned that it might be a scrutiny issue as opposed to a board issue. But I will take that away and investigate. We can always, if that is the case, recommend that health scrutiny consider that. So it does get addressed.
Okay, we'll look through that, and then no doubt there'll be other things cropping up that we need to look through. So let's take it from there. Okay, thank you everybody for coming along. I'm just conscious that you've been very quiet there, Jeff, and I'm not saying it's unlike you to be quiet, but before we sign off, is there anything you wanted to just bring to us quickly?
No, not at all. It's been helpful to be in the meeting. I was going to comment a bit on the Falls commentary earlier, but I'll link in with Nicola so we can give those responses in, and very supportive of those. I think it's been very helpful today, and particularly the sort of general interest across the city, isn't there, around all these matters, and the drug paper was very helpful, and the vaping one. And the only thing I'd say about the vaping, which I was prompted, really was around the inpatient for mental health services that we provide for local people, and what a game changer the vaping switch has been for an alternative to people who are addicted to tobacco. So it's been a really big, significant shift. But of course, there's a worry, isn't it, around children about that issue. So it's all very relevant and helpful for me to take back to our departments as well. But I'll link in with Nicola to help give some extra feedback on the Falls questions.
And certainly from our perspective, vaping is a very useful tool in ceasing smoking, which was why we felt very strongly that it needed to be a smaller number of or not a number, a smaller amount of flavours on offer, rather than sugar-coated bubblegum, whatever, things like that. Whereas if you had sort of 3 or 4 fruit flavoured or natural or fruit flavoured, that was part of that remit. So yes, and I think it is a case of let's watch this space, and we'll make sure that we're putting in any input when input is needed. So that will be really useful. So Thank you, everybody. We're a little bit later than hoped, but on the other hand, I think we've done a lot, had a lot of information today, and very useful information. So thank you to everybody for coming along. I do appreciate it. Okay, thanks, team. All right. Thanks, Elliot, for your input today. Much appreciated. Thanks. Bye.